Now we have come to the last and the fourth and the last presentation for this morning, and it is touching upon a very important aspect for us as family physicians regarding shared care. So the next theme would, the title would be Mastering SLE and Connective Tissue Disorders in Shared Care. To introduce the speaker and take over the proceedings, I call upon Dr. Lalantha Senaratne, Specialist Family Physician from Base Hospital, Homagama. Over to you, madam.
Thank you, Dr. Fazana. It's a great pleasure to introduce Dr. Sujeewani Kurukulasuriya. And Dr. Sujeewani Kurukulasuriya, a senior lecturer and head of the Department of Pharmacology at the Faculty of Medicine, University of California, is a distinguished consultant rheumatologist. She holds an MBBS and MD from the University of Colombo and has served as Assistant Secretary in the Association of Rheumatology and Medical Rehabilitation from 2009 to 2013, while also being a member of Ethics Committee at the University of California since 2012. Her primary research interests focus on osteoarthritis and spinal cord injury, resulting in significant contributions to peer-reviewed journals. Please join me in welcoming Dr. Sujeewani Kurukulasuriya, who will be serving as a resource person today to discuss SLE. As well as I have to tell, she's a very supportive consultant for family medicine. She contributed as an examiner for us as a pre-MD as well as MD as well as all the selection exams. Over to you, Dr. Sujeewani.
Yes, thank you, Lalantha. Very flattered by those words of introduction. I thank the college and the council for giving me this chance to stand in front of you and present this short presentation. So I think the topic is slightly different from what was given to me. So it's shared care in systemic lupus erythematosus and other connective tissue disorders. Are you hearing me well enough? Okay, thanks. Okay. How does this happen? That way this goes? Ah, yes, thanks. So shared care involves establishment of partnerships between professionals and laymen who share a common goal. Okay? So when we talk about connective tissue disorders, it is a very wide area. At one end you get the genetic type of connective tissue disorders, which are like Ehlers-Danlos syndrome, then Marfan syndrome and its variants, erythematosus bullosa, that sort of genetic connective tissue disorders. And at the other end, you will get the autoimmune types. The autoimmune types actually involve more than this. Vasculitis should come here. But due to time constraints, I will be limiting myself to these autoimmune conditions. So I will be mainly focusing on SLE, and I'll be touching upon the others. Okay? So I'll see how the time goes. If I'm sort of overstepping, I'll have to make it short at the end. Okay, starting with SLE. Okay, so starting with SLE, now in suspected SLE, we are suspecting SLE, then there are certain criteria that we go by in diagnosing SLE, right? So here, sorry about the mess, so I think I'll do it like this. So when, if we are suspecting SLE, we first need to do a NA level. You all know that, and that's by immunofluorescence. So the titer at the moment is 1 in 160, not 1 in 80 or 1 in 100, okay? So 1 in 160, if we have a positive test, then we look at the criteria, the EULA ACR criteria. EULA means European Alliance for Associations of Rheumatology, and ACR is American College of Rheumatologists. So they together have put down this criteria, right? So different features have different weights. Okay? Now, for instance, now still, if we are talking about the clinical domains, there are the constitutional features like fever. Then you get the hemolytic type of clinical features like leukopenia, thrombocytopenia, and autoimmune hemolysis. Neuropsychiatric ones like delirium, fits, and seizures, psychosis, right? And the mucocutaneous ones like non-scarring alopecia, discoid lupus, acute onset SLE, subacute onset SLE, under mucocutaneous features. And then under serosal ones, you get the pericarditis and the pneumonitis, okay? And the musculoskeletal ones would be joint involvement. Then you're looking at the renal ones where you're looking at the urine protein excretion, right? And you're looking at the renal biopsy at one stage where you are looking at the WHO classification of what stage your renal biopsy is in. So you will notice that, for instance, if it's WHO class 3 or 4, right, you straight away get 10 points there and it's SLE. But some other features might score much less than that. Okay, I hope the trainees are clear with that, right? Okay, so those are the clinical features, and then you get the immunological features. We are looking at the complement levels like C3 and C4. It has a certain score. Then low C3 and C4 has a different clinical score, right? So complement levels, is it one that's reduced or is it both reduced? Then you get the SLE specific antibodies like anti-dsDNA. Then you get the antiphospholipid type antibodies, the APL antibodies, which can be anticardiolipin or anti-beta-2 lipoprotein antibodies, right? And the lupus anticoagulants. So those have a certain score. So I took you through these to say, now if the ANA is positive in a significant titer, then if you have 10 points on this, then we can diagnose SLE. Right? Then the other problem is in early stage, we might not have this amount of clinical features, right? So then we look at the score. If it's less than 10, we then look at the immunological scores. If it's 0 plus clinical scores of more than 8 or more, plus we look at photosensitivity. So if that is present, we say again, we can say there is SLE, right? Then on the other side, what if the patient is ANA negative? Can it be SLE? Yes, still possible, right? So then you look at the complements level and the phospholipid antibodies, right? Still, you can have a clinical SLE in spite of a negative ANA test. Any questions on those? I'm particularly concentrating on trainees that may be here. Everything's okay, right? Okay, thank you. Then we get on to the next slide. Yeah. So as I told you, in early stages, we might not have enough criteria for diagnosis of SLE, right? And then the other thing is in negative cases and organ dominant cases, patient presents as a renal failure, but when you go back, it might be an SLE. So in those cases, it might be difficult to catch SLE at the beginning, right? Yeah. Then the unwise choices are, if you have a ANA positive at one point, don't go and repeat it. With treatment, it can get negative, so you're wasting money, right? And if your patient is getting better, don't spend on serological tests, right? So that is not warranted, okay? And don't forget the cheap, the relatively cheap urine analysis, because that can help in sort of maybe completing your criteria to say it's SLE, right? So who is more likely to develop severe SLE? It could be the usual patient is either a child, okay, or a male patient, or patients with low complement levels, patient with phospholipid antibodies, and patients with interferon signatures, with high interferon signatures. That means now interferon works on mRNA, and the expression of certain types of mRNA will be high. So interferon signatures, you are looking at those mRNA types, you're measuring the mRNA there. So any of those would push you to having, push you to a higher possibility of having more severe SLE, right? This type of patient should ideally initially be referred to multidisciplinary care, and once there's a treatment plan in place, referred back to the physician. Okay? Okay, so we spoke about coming on to a diagnosis. Now, once SLE is diagnosed, what should we do? So I'm basically basing my talk on this, on the 2023 EULA criteria. So it's very recent, it's done, set up in October actually, and so it's very new for you, right? So, let's look at the 2023 EULA criteria. I looked at this article as well, right? So that means the American Lupus Society is also recommending the same. So generally what are we planning at in this criteria? We are looking at long-term patient survival, right? And we are looking at prevention of organ damage and looking at improving the quality of life of these patients. Fair enough, right? So in this criteria, they have what we call overarching principles. That means very general principles, what we want in place. And then we have the specific principles. So talking about the overarching principles, we are now every SLE patient, likewise, or for that matter, any patient with autoimmune disease should have multidisciplinary care, should have individualized care. Okay, very important, individualized care and multidisciplinary care, right? So the patient needs that, and there should be shared decision making with the patient. And the cost of treatment has to be taken into consideration for the patient and maybe for a government, right? So when you take the cost into consideration, you have to think about the cost for the patient, as I told you, and cost for the society by the way of considering work participation of the patient and social participation. Okay, so especially in at this point of time, cost is very important. So that was overarching principle A. And in the second overarching principle, they say that we must measure disease activity, right? So this disease activity should be measured at every visit. Now they don't say about spacing of the clinic visits. This could be at the discretion of the physician, right? So every clinic visit, the disease activity has to be measured. So one easy way is having this, or you get it on your phones actually. So one easy way is having, if you have a sort of a book for the patient, to have that print out of the disease activity you are going by, maybe in his book, so that you can go through quickly, right? So this is important because just looking at the patient, okay, the patient may look better, right? But then say, okay, you look better, it's very nice, okay, doing much better than last time. So that's not the way you should be doing. You should be looking at a score, right? Even in rheumatoid arthritis or SLE. So you're looking at a score of disease activity at each visit. Then annually, you're looking at the damage index. Okay? So these are the activity scores. There are a lot here, as you can see. But what we will be going through mainly is the SLEDI, and the more modified version of it is the SLEDI 2K. Then recently what you get in red there is what has been proposed by the EULA, the SLE DAS. Now in rheumatoid arthritis, you know there is a DAS score we talk about, the DAS 28, right, to monitor patients. So you get a SLE DAS in SLE patients for monitoring as well. Then the SLIC ACR damage index is for that annual thing I told you, where you are looking at the damage caused by the disease to the patient annually. Okay? So disease activity scores at every visit and damage index at least annually. Okay? So this is how the patients would behave. 70% would have a relapsing remitting disease. Then there is a fortunate 15% who will have prolonged remission after one episode of treatment. And unfortunately, there is a 15% who will not respond to treatment, who will have persistently high disease activity. Yeah, so we are still on overarching principles. So the next overarching principle is general non-pharmacological measures such as smoking cessation, then sun protection, photoprotection, more physical activity and psychosocial well-being. Smoking cessation is very important. I know most of our patients are females, but and most of our community might not be smoking, but you have to ask, right? Especially because smoking, if smoking is going on, the antimalarials, the hydroxychloroquine that we give may not work. And even the expensive biologicals such as belimumab will not work properly if the patient is continuing to smoke. Okay? Then the next overarching principle is when you're looking at pharmacological interventions, you're looking at the patient characteristics, right? Then you're looking at other comorbidities in the patient, okay? And then you're looking at patient preferences also. Okay, so when deciding what drugs you're going to treat with, you have to look at all this. Yeah, so then the other thing is you have to, especially in early disease, you have to screen for end organ damage. Usually the time of presentation to the doctor is about 2 years, generally even globally, from the onset of the disease. So it's a big delay actually. So especially in the initial years, at least screen for end organ damage, especially concentrating on lupus nephritis. Because the onset of lupus nephritis will be more towards the early stage of the disease. Okay, so now this is a slide that has been put by the EULA, has been put forth by the EULA. Here we are looking at treatment of non-renal SLE, where there is no lupus nephritis, right? So as you see in one corner, there are the general measures that I spoke to you about, like sun protection, psychosocial well-being, then physical activity, that sort of thing. And then if sometimes the patient may need aspirin, acetylsalicylic acid, or may need vitamin K antagonists like warfarin, where there is antiphospholipid syndrome or antiphospholipid antibody positivity. So those are general measures. And then here now they have divided SLE into mild, moderate and severe. Next slide would be how we do that, right? So in all diseases, hydroxychloroquine should be offered to all patients unless there is a contraindication or it is ineffective. Unless one of the two, you have to continue hydroxychloroquine in every patient. Then coming on to glucocorticoids is generally given to all patients, but we like to take off the glucocorticoids as soon as possible, or at least aim at maintaining less than 5 milligrams of glucocorticoids, right? So here I will tell you a bit about steroids. So the 5 milligrams here is prednisolone that they are talking about. So the equivalent of methylprednisolone will be 4 milligrams, right? And you know, if we are comparing it with cortisol in our body, I might complicate you a bit. So if we are comparing the potency of these steroids with cortisol in our body, of prednisolone it will be about 4 times more potent, and methylprednisolone will be 5 times more potent. But forgetting that, here the 5 milligrams is for prednisolone. If it's methylprednisolone, it's 4 milligrams, right? So we our aim is to keep the steroids at 5 milligrams or less, or ideally take it off, right? So that's common for all stages of disease. Then in mild disease and in first line of moderate disease, if we are unable to maintain that steroid dose, we want remission, but that steroid dose and the hydroxychloroquine is not good enough in maintaining it, then we add other immunomodulating agents like methotrexate, azathioprine or mycophenolate mofetil, right? Then in moderate disease, second line would be still mycophenolate mofetil. And then you get the biologics coming in if the higher ones the upper ones are not working. It would be things like belimumab. Then there are calcineurin inhibitors. These are drugs like cyclosporine, tacrolimus. Then there's a new one. I'll introduce you to it in a few minutes. Okay. Then in severe disease, we talk about cyclophosphamide being given to patients. And if cyclophosphamide is not working, we can try rituximab. This is all for non-renal disease, non-renal SLE. Okay, so we spoke about mild, moderate and severe disease. So these can be referred up all the time. So how we say something is mild disease is the patient may have constitutional features. Then we go on the percentage of body surface area involved by the rash, right? So if it's less than 9%, we call it mild, right? Then we look at the platelet count. So full blood count is important. So if the platelets are between 50 to 110 to the power 9, we call it mild disease. So as you go down, and the other thing is the disease activity, which is the SLE of 6 or less, right? So then we call it mild. So then in moderate, what happens? The platelet counts fall further. It's between 20 to 50, right? SLE score is climbing, and the area involved by the rash is increasing. In severe SLE, the area involved by the rash is even more, is double of what it was in mild disease. And the platelet count has dropped to less than 20. SLE score is climbing to more than 12, right? So these can always be referred up, don't worry about it. So depending on this, you will decide whether it's mild, moderate or severe disease. So depending on that, you will go back. If you go back, you will be, depending on whether it's mild, moderate or severe, you will be thinking of treatment options. So this is all pharmacological treatment. Yeah, so what about hydroxychloroquine? They say 5 milligrams per kg per day, right? Unless there is retinal toxicity, right? So when should we refer our patient if we are starting on hydroxychloroquine? Annually, they say at the moment, but the first 5 years it might be safe to give even without the eye surgeon seeing the patient and screening for maculopathy, right? So annually, once established, send your patient to the eye surgeon to look at maculopathy, right? Yes, so hydroxychloroquine would be 5 milligrams per kg per day, right? So you understand this, if a 60 kilogram person, it will be around, about, too bad in my maths actually. So 5 into, I'll do that later, but it's about 200 milligrams BD for a week, for 5 days, or if you are giving it daily, it's 300 milligrams per day, right? 300 milligrams daily or 200 milligrams BD for 5 days of the week, where you are giving 2 days as a drug holiday, right? Okay. Okay, then I spoke to you about glucocorticoids that we need to maintain at least below 5 milligrams or wishfully take steroids off completely. Then in severe disease, we sometimes need steroid pulses, right? So this pulse, you must be knowing from your medical student days, it's 1 gram what we usually know, but it can be as less as 125 milligrams also. So we will give those pulses for 1 to 3 days, right? Yeah, so I spoke to you about this actually. Patients who are on hydroxychloroquine, on glucocorticoids, where we can't maintain the steroids at 5 milligrams or less, then we think of adding other immunomodulating agents such as mycophenolate or azathioprine or methotrexate. Yeah, still reiterating the same thing that I told you. You see in mild disease and moderate disease how we are adding the methotrexate, azathioprine and mycophenolate mofetil. Yeah, so in life-threatening disease we give cyclophosphamide plus steroids. Okay, then there are the, where you are looking at the individual areas like skin involvement, the patient is first treated with local treatment. The local treatment can be a steroid or a calcineurin inhibitor like tacrolimus, right? Then you think of systemic treatments such as maybe steroids and maybe belimumab or anifrolumab. Those are the new, that's the newest biologic, or methotrexate, mycophenolate, or may be considered as second line therapy. Okay, so skin, try local treatment first. Then in neuropsychiatric conditions, there are two aspects we have to look at. We have to look at treating the inflammation and treating the thrombotic events, right? So in treating inflammation, what do? We give mainly steroids and cyclophosphamide. In treating the thrombotic events, we might need to consider aspirin, right? That's salicylic acid, especially in patients who have coexistent antiphospholipid syndrome or where the antiphospholipid antibodies are positive. These are the hematological conditions that can be seen in SLE. You can get autoimmune cytopenias, then SLE-induced immune thrombocytopenia and hemolytic anemia, right? So in autoimmune thrombocytopenias, I know I'm boring you all to death, but then for completeness sake, I'm going through this. So in autoimmune thrombocytopenias, we give high-dose glucocorticoids and immunoglobulins, and then if those are not working, we can give intravenous cyclophosphamide, and then maintain with rituximab, azathioprine, or mycophenolate mofetil. Yeah, so that was all that bad stuff was about. That was bad enough, I know. That was about non-renal SLE, and now that we come to renal SLE. So the lifetime risk of lupus nephritis in SLE patient is 20%. So 1 in 5 of your patients will get renal involvement, right? So the risk factors are again the male SLE patient, the patient with hypertension, right? The patient with high disease activity, and who has a already baseline high creatine level, right? So these patients are more likely to develop lupus nephritis. So this is the chart that they have for lupus nephritis, right? So here the general measures we have will be those for renoprotection, right? So for anywhere, even in diabetes where we are looking at renoprotection, we like to give a ACE inhibitor or a angiotensin II receptor blocker, right? Then to keep the sugars in control, we like to give a SGLT2 type drug. And then we will give things like warfarin, a vitamin K antagonist, or heparin if the patient has concomitant thrombotic tendencies. That means like concomitant lupus disease, sorry, antiphospholipid syndrome, or the antibodies being positive. So here how they divide the lupus nephritis is initial treatment and subsequent treatment. Here again all patients should be on hydroxychloroquine unless contraindicated, right? So then the glucocorticoids may be given IV at a dose of 0.3 to 0.5 milligrams per kg per day. Then we drop to oral steroids. Then mycophenolate goes right through from the initial stage to subsequent management. Then if we are giving low dose cyclophosphamide, that will be followed up with azathioprine. Okay? So rest of it you can look through. I know it's a bit boring, right? Okay. So then what are our targets in lupus nephritis? We are looking at the urine protein excretion. In the first 3 months, we want the urine protein excretion to drop by 20% at least. In 6 months, we want it to drop by 50% at least. And at about 2 years, we want the urine protein excretion to be 0.5 to 7 grams per day, right? So that was about lupus nephritis. Yeah, so I have told you what I should be telling in the previous slide. Yeah. Then patients at high risk for kidney disease would be patients who have already a low GFR, and if there's histological presence of cellular crescents or fibrinoid necrosis or severe interstitial inflammation, and then high dose, we will use high dose cyclophosphamide plus high dose methylprednisolone in these patients. Okay? So then after all these drugs, if the patient is achieving remission, the first thing we like to take off is the steroid. Okay? Yeah, then in thrombotic antiphospholipid syndrome, we will be giving aspirin, right? And then we will be giving vitamin K antagonists like warfarin with the first arterial thrombotic event or the first unprovoked venous thrombotic event. That means if a patient has had surgery or trauma and developing venous thrombosis, it's a different case. That's provoked, right? So first unprovoked venous thrombosis or first arterial thrombotic event, we will be starting on things like warfarin, right? Yeah, then the immunizations have to be in place. Of this, pneumococcal immunization is very important. Then, yeah, herpes zoster, human papillomavirus, and COVID-19 at one time, then influenza, right? These have to be, the vaccinations of the patient has to be in place. So what is this chart about? Now, the one on top shows you the conventional approach we have. Conventional approach where you see the damage indexes shown in red is going very high with time. And there are many relapses. Below you see treat strategy. What does that mean? That means we are looking at either achieving remission or achieving low disease activity, right? So remission would ideally be hydroxychloroquine plus steroids less than 5 milligrams. That is remission, and SLE of 0. SLE 0, hydroxychloroquine plus steroids less than 5 milligrams. If we can't achieve that, at least a SLE of less than 4, right? And hydroxychloroquine and a steroids less than 5 would be called low disease activity. So that is what we call treat strategy. In those patients, if you do that, you can see the damage index is much less and the relapses are much less as well. So that is what these recommendations are about. Okay, so the new breakthroughs, the recent ones are anifrolumab, which is the new biologic, and voclosporin, like cyclosporin, this is the new one. So those are the 2 new things that have been approved for treatment. Okay, that was SLE. Have I taken a lot of time? Is it okay to continue? A few more slides. Okay, right. Mixed connective tissue disorders, right? Okay, these are only a few slides. So I have based my little talk on this article, which I thought was very good, right? Now, MCTDs are a distinct clinical entity where you get some features of SLE, some features of rheumatoid arthritis, scleroderma, and myositis. That won't do. You have to have the U1 RNP antibodies positive at more than 100 100 international units per milliliter, right? So here these are the different criteria for, different types of criteria for diagnosis of mixed connective tissue disorders. Most commonly used are the Sharp criteria, the one on your left hand corner, and the Kahn criteria, which is on your right hand corner, right? So here essentially the U1 RNP antibody has to be more than 100 international units per ml, right? That plus, now in Sharp's criteria they need the anti-SM antibody. Now don't get confused there. This is anti-Smith. Anti-Smith antibody is in SLE, anti-smooth muscle antibody is in liver disease, not here, right? So both are written a bit similarly. So here anti-SM is anti-Smith, okay? So Sharp's criteria, they say the U1 RNP plus the anti-Smith has to be positive, plus one of the following 4, which could be myositis, pulmonary involvement, Raynaud's phenomenon, or swollen hands, which we call scleroderma, not scleroderma, scleroderma. Initially where all fingers would be swollen, right? And at the other corner you get the Kahn criteria, where the U1 RNP positivity is necessary, plus 2 of either synovitis, myositis or scleroderma, right? So most commonly used are the Sharp's criteria and the Kahn criteria for diagnosis of MCTDs, right? So the key thing is features of other CTDs, but you need the U1 RNP antibody positivity. Okay, then here also you need to measure the disease activity. Again, SLEDI for SLE predominant MCTDs, and there's called the U-star AI. AI is activity index. So these can be used for measurement of disease activity. Yeah, then there are things called, there are the overlap syndromes, right? Now, in overlap syndrome, the difference from MCTDs, here you are getting more than one fully defined rheumatological condition, more than one, right? So these overlaps, one could be MCTDs. MCTDs comes under overlap, right? So the other thing is antisynthetase antibody, antisynthetase syndrome, and the other one is the polymyositis scleroderma combination. Okay, so antisynthetase antibody, the key feature there is you have various amino acyl tRNA synthetase enzymes that come into play, and here there is interstitial lung involvement, right? Then the polymyositis scleroderma combination, here you get the polymyositis scleroderma antibodies and the Raynaud's phenomenon, tendon inflammation, and again lung disease. So that's for overlap syndrome. And how do you treat overlap syndrome? You will be treating the clinical features that are prominent, either symptomatically, failing that you will be giving disease modifying drugs, right? Then primary Sjogren's also comes under CTDs. So I'm not going to take you through this. This is the diagnostic criteria. And here, the dryness, you know, may be of the mouth or the eyes, right? So you first treat locally. That means you give sort of local treatment before thinking of systematic treatment. Of treating the whole body. The word must be systemic treatment. Before treating systemic treatment, you will be treating locally, right? Okay, so the other thing is dryness. If it's in the mouth, the salivary gland has to be assessed before treating locally, right? So you assess the salivary glands, then you treat locally. Failing that, if there are systemic features, you give other disease modifying drugs, right? So there's actually no guidelines to say which one is better, right? So when replacing steroids with other disease modifying drugs, there is no guideline. So you can use your choice, discretion actually there. Okay, so I have done with those, and this is not from the internet. This is, may I present this to you? So what I think, what should be in shared care, patient is the center, no two words about it, right? And there's a rheumatologist in one corner, and the primary care physician there. Between them, I think disease activity is what is important. If the disease activity is high, the primary care physician should be referring to the rheumatologist. If the disease activity is stable, the rheumatologist should be referring back to the primary physician. Then if there is organ-specific disease, we get in touch with the nephrologist, the dermatologist, or maybe the neurologist. And very importantly, we can't forget the support groups. Sri Lanka, there are support groups. For rheumatoid arthritis, we have support groups. For osteoarthritis, we have. For SLE, we have. So the patient should be in contact with support groups as well. So that's what I present to you as shared care of connective tissue disorders. And I'm happy to answer any queries that may arise.
Thank you very much for your very excellent, very fascinating and interesting lecture. I think it's very, good for our clinicians as well as for our postgraduate trainees. I think there are a lot of questions they must have. This is over to you all, so you can ask any questions because he leaves.
Yes. You want this? Right.
What's your opinion on ivermectin as a therapeutic agent for SLE?
Not in the guidelines. So anything that's not in the guidelines, I would not say it's worth trying. No. Anything else?
You said for the severe SLE, the ultimate treatment is the rituximab. Yeah, is there a place for flex?
Not very clear, doctor. I'm sorry.
Yeah. For the severe SLE patients,
Yeah.
the third line or fourth line treatment is the rituximab.
Yes. What I said is, for severe SLE, it's cyclophosphamide, right? Failing cyclophosphamide, we can try rituximab.
Yeah, rituximab is the immunosuppression agent.
Yes.
Because before we are giving the rituximab, we have to do the, septic screen.
The
Septic screen.
The septic screen, yeah, even for, it is common for all biologics. So belimumab, even that applies.
Okay, is there a place for plex therapy for SLE patients, the ultimate treatment?
Place for?
Plex. Plex means plasma exchange.
Plasma exchange. No. There is a place for immunoglobulins, but not for plasma exchange, no.
Yeah. My last question is,
Yes.
is there a disease entity of SLE optic neuritis? Is there
Problem with my hearing, I think. I didn't get that.
SLE optic neuritis?
SLE?
Optic neuritis.
Optic neuritis. Yes, that is possible. Yes, especially you're now. That is one query. So when at the annual checkup for hydroxychloroquine, the eye surgeon will be looking one thing at the cumulative dose of hydroxychloroquine the patient has been on, right? We'll be looking for features of maculopathy. We'll be looking for any deposits in the eye called cytoid bodies, you might remember, and definitely, yes, optic neuritis can occur in SLE, true.
Right, thank you very much.
Okay.
Any other questions?
So, madam, as primary care physicians, how could we advise non-renal young female patients with non-renal SLE while they are getting ready for pregnancy? What are the drugs we could continue until they see?
Very good question. Yeah. Now the question was in patients with non-renal SLE, what drugs can be continued, what drugs have to be stopped. Hydroxychloroquine is completely safe during pregnancy, right? And that dose of steroid is okay to be continued, right? Then the things, the disease modifying agents that cannot be continued in pregnancy will be methotrexate, mycophenolate mofetil and cyclophosphamide. All other disease modifying drugs can be continued in pregnancy. So hydroxychloroquine is a definite yes. Any other questions?
Sujeewani, thank you very much for the very informative lecture.
Thank you.
When you say that you are bringing down or maintenance, right? To bring down the steroid dose, right? Are you going to maintain the HCQ at or bringing down that dose?
No, that will be at 5 milligrams per kg.
So maintaining the HCQ but bring down the
same dose, yeah.
Yeah, right. Thank you.
Madam,
Yes.
what will be the pre-pregnancy counseling that we have to adapt to a patient with SLE?
Yeah, pre-pregnancy counseling is not very different from what you would be telling another patient, right? So one thing you have to tell the patient, it's an autoimmune condition, right? So as long as you're alive, it's within you. There are times it will show up, right? And that there may be times of remission, but nobody can predict the period of remission initially, right? So in pregnancy, unless there is renal disease, there is no specific reason that there should be an increased risk, right? And then they should be told about the safety of hydroxychloroquine throughout pregnancy.
Thank you.
Right.
Just one more question, madam.
Yes.
Is there a relationship between vitamin D supplementation and managing disease flare-ups or SLE?
Yeah. Now, disease flare-ups and vitamin D, there is nothing like that. But since we are using steroids, yes, right? So especially if they are using steroids of more than 7.5 milligrams per day, vitamin D supplementation of about 1,000 international units per day is recommended.
Another question, if the patient is wishing...
Who is talking?
Wishing to be a pregnancy,
Yes, okay.
expecting a pregnancy, what is the advice you are giving?
Patient has SLE, is trying to...
SLE, not in acute stage.
Yeah, so better actually to try a pregnancy with low disease activity, when you are having low disease activity. Sort of remission or at least low disease activity, because the chances of sort of having a miscarriage is more when the disease activity is high. And then of course the same things I told the other lady, like what drugs are safe to be continued in pregnancy, and if there is especially no lupus nephritis, that there is no added risk due to pregnancy. I think that's what you should be telling your patient.
Thank you.
Okay.
In the absence of any questions, shall I ask a question?
Yes.
So now you mentioned that we have to start with SCQS, and what are the criteria to start steroids or the glucocorticoids, and what are the criteria to take the steroids out?
Yeah, so we'll be again on disease activity. Everything is based on the disease activity scores. So HCQS, if the patient is adequately controlled, good enough, right? But still, if the patient's disease activity is high, then you can add the steroid. Then reducing the steroid also will depend if the disease activity is reducing. So the disease activity which is good to go there is the SLE. So if it's less than 4, you can try reducing the steroids. Ideally, we like no steroids, right? Or at least maintain less than 5 milligrams.
Thank you. And you talk about non-renal as well as with renal complications. So there's another entity, so SLE-like syndrome.
Yes.
So in that instance, what are the things you should give the advice, or what are the things you would like to do?
Yes, even in SLE-like syndrome, if the ANA titers are high enough, it's better to start them on hydroxychloroquine.
Is it same as the guideline is same as for the other SLEs, or there is different?
Actually, the EULA hasn't even touched on SLE-like syndrome. I know this and I'm familiar with this, but yeah, same sort of hydroxychloroquine should be in place even in those patients.
And sorry, I'm asking, how often, how long we have to continue HCQs for these patients with SLE-like syndrome?
Yeah,
how long we have to give HCQs for this?
How long?
We have to give HCQS for SLE.
Yeah. No, HCQS is a lifelong thing.
It's lifelong.
Yeah.
Okay.
But eye surgeons would be looking at the cumulative dose of hydroxychloroquine. Okay. So, especially when looking at retinopathy. If they do develop retinopathy, of course, we can't continue. We'll have to go for other options.
Okay, then if there are any other contraindications, we can go lifelong.
Definitely, you can go lifelong in HCQ.
Okay, thank you very much. It's very informative. Thank you very much for your coming. It's very honor for us, and there's a token of appreciation. Sorry.
Yes.
Concomitant factors that may predispose to hydroxychloroquine retinopathy?
The features that may predispose to hydroxychloroquine retinopathy. Certainly, it would be the cumulative dose of hydroxychloroquine.
other drugs?
No interactions that I know of.
Madam,
Yeah.
what is your take on the safety of HRT with patients on SLE?
HRT, you can especially now, here the problem is whether they would develop a thrombotic event, especially if the phospholipid screen is negative, phospholipid antibodies are not positive, or there is no antiphospholipid syndrome, you can definitely continue the normal HRT. If it is positive, we will be thinking of using very low estrogens. Estrogen is the problem, no? Progesterone won't be a problem.
Is there a particular type where it's only estrogen or with progesterone, or?
No, it's
you'd
either
say
progesterone alone or estrogen-progesterone combination. So you'll have to shift to a progesterone only thing.
Only is
Only-
safer,
only.
no? Yeah. Thank you.
Okay, looks like I can go home. Right, okay.
Thank you, madam, for that very informative and elaborate presentation. As a token of appreciation, Dr. Lalanta Senaratne, specialist family physician, will be presenting the speaker with the token of appreciation.